Buongiorno a tutti. Hello to everybody. If for you is fine, I would probably start the class. Maybe some of you is still having the coffee and will join us in a few minutes. But probably it's better to start, so we will not steal time to the next speaker. I will give this, if you agree, I will give this talk in English because I think there are few international guests who don't speak Italian. Is it correct? Or everybody is speaking Italian here? No? Okay. So I will give this talk in English, but obviously feel free to ask questions in Italian if you feel more comfortable. There's no problem. And feel free to interrupt me at any time to ask questions or to make comments. My name is Francesco BARONE-ADESI. My background is in medicine and surgery, but I've been working as an epidemiologist in the last 15 years. And I was asked to give a talk in during this school about some methodological issues that can arise during the conduction of an epidemiological study. Just to be sure before starting, who does know what epidemiology is? Raise your hand. Coraggio. Have you ever heard about epidemiology, or am I talking about something that is completely new to you? Okay, let's do another step back. Who do have a background in medicine or biomedical science? Okay, the majority of you, okay. The other people probably come from philosophy and something similar, I suppose. Okay, but also for the people coming from the medical side, the concepts of epidemiology are not that known, that obvious. Is it correct or not? Because this is very important, so we can decide. I mean, this talk is for you, so we can decide together what kind of level to keep this talk. Okay, so probably my first slide was a good hit because I was in doubt whether or not starting from here, but it seems that it is relevant. What is epidemiology? Usually when I go to social situation like dinner, work dinner or stuff like this, and I say to people, I'm an epidemiologist. Half of the people do not understand what I do, and they usually leave me to try to go for the buffet and to take some pizzettas. And the other half try to make some kind of easy talk, like just to react, and this usually becomes a kind of hilarious because very often they show not to know what epidemiology is. So most of the people usually say, oh, wow, so you must be very, very involved in Ebola or in the new flu season. And I say, well, no, not necessarily. Actually, I never work on infectious disease. I'm an epidemiologist, but I don't work on infectious disease. To make the story short, epidemiology is not necessarily studying infectious disease. Epidemics are not necessarily epidemics of infectious disease. Epidemiology is a branch of medicine that works on populations and group of people instead of individuals. So as you can see, the word epidemiologist comes from ancient Greek and means something like reasoning about people, reasoning about a group of people. More than an independent branch of medicine, you can see epidemiology as a set of quantitative methods. that can be used to study any aspect of health, okay? So we can use this set of methods that are usually built over statistics to measure and to analyze different aspects of health. Modern epidemiology usually has three main domains. You can, the first domain, as in any kind of, in any science, is to describe phenomena. So in this case, the aim of descriptive epidemiology is to describe the health of populations or group of people in a quantitative way. For example, try to explain whether the rates of a specific disease are increasing over time or not, for example, or whether there is a difference between two different regions in the rates of one disease. A second part of epidemiology that will be very relevant for the talk of today is about identifying the causes of disease. Try to understand whether, why some people get lung cancer and some people not. Whether smoking is a cause, a risk factor for lung cancer or not. This part of epidemiology is called analytic epidemiology. A third part of epidemiology is instead is concerned with the evaluation of health intervention. So, for example, every time, and this is obviously the part of evaluative epidemiology, every time that we need to evaluate whether an intervention, an health intervention is effective or not, we need to run an epidemiological study. Do you have an idea of what is the most famous type of epidemiological study that we carry out when we want to evaluate the efficacy of a specific treatment? Come on, I can't hear you. Have you ever heard of randomized controlled trials? Okay, randomized controlled trials are a type of epidemiological study that is carried out to evaluate whether a treatment, usually a drug, but not necessarily, a drug is effective or not to cure a specific disease or to improve the prognosis or whatever, okay? So the third part of epidemiology, the third aim of epidemiology is specifically central for all the medical research. Please. Well, it depends on which field you are working on. Because what you said is true, is correct. You say, well, sometimes people do not feel that a randomized controlled trial belong to epidemiology. In fact, if you buy any book of epidemiology, you will find a chapter on randomized controlled trials. Not necessarily the book will be devoted all on randomized controlled trial. Will be usually just a part, but it's always there, and it's very important because most of the principles of epidemiology, in fact, are based on the principles on randomized controlled trial. What is the big difference between the analytic epidemiology and the randomized controlled trial? You're right, there is a very important difference in this kind of studies. Exactly. That what try to yes, but what is the difference? I could, for example, I could carry out an epi study in which I follow people that take a drug and people that do not take a drug. This would be this would be still a study of clinical epidemiology, so an evaluative study, but it would not be a randomized control trial. What is the difference? What is the extra element that the randomized control trial has? The randomization, okay, but this is very correct. But there is another thing that that comes before the randomization that is very important, and this probably you already said, but not in an explicit way, and is the fact that the first two examples of epidemiological studies are called observational epidemiology. We do not make any experiment. We just observe what happened to the subject. So, for example, I take 100 people smoking, 100 people do not smoke, and I follow them over time to see whether the risk of getting lung cancer is different, okay? I'm not intervening in their life. I'm just observing them in the same way as an astronomist could observe what happened to stars or planets, okay? Instead, the most important difference in clinical trials is that you make an intervention. You intervene in the life of these people, and usually, often you will intervene in a very important way. You give a drug to some of them, and you don't give the drug to some others. So in this case, we will see that this has very important implications, okay? So the reason why sometimes clinical trials are not immediately linked to epidemiology is that you often think only to epidemiology as an observational science, but in fact there is also an interventional part of epidemiology in which clinical trials are the typical example, okay? Okay. Sorry, I thought there was... So, just to give you an example, what I was talking about, this is an example of descriptive epidemiology. I'm just describing as the prevalence of obesity is changing in different countries over time. As you see, there's nothing here related with the infectious disease, but still I can talk about an epidemics of obesity that is happening, is occurring in all industrialized countries in the last 30, 40 years. This is an example of analytic study. These are some results from the famous doctor cohort of Sir Richard Dole. That was the first study that showed that the fact that smoking people tend to live less than non-smoking people. So you can see here that the expectation, the expected survival for subjects, smokers and non-smokers was different in this, and there was basically a shift of 7 years between these two groups of people. Studies like this one were pivotal to identify smoking as a cause of different diseases like lung cancer and myocardial infarction. And this is instead an example of evaluative epidemiology, like, and this is the most typical example, that is a randomized control trial in which I compare the survival of people taking a specific drug and people who do not take the drug. And I see whether the prognosis is different for these two groups of people. Epidemiology was central in biomedical research, at least in the last 50 years. Consider that most of what we know about the causes of non-communicable disease has been obtained through epidemiological studies. If we know now that smoking is associated, is a risk factor for lung cancer, if we know the effect of diet on different diseases like myocardial infarction or metabolic disease, this was obtained not through a lab experiment, but through some descriptive first and then analytic epidemiological studies. And then, as I already mentioned, clinical epidemiology is essential to evaluate whether a new medication is effective or not. So whether we should give a drug to the population or not. However, the feeling, sometimes people perceive epidemiological research not as a very robust type of biomedical research. The idea, especially if you just read the normal newspaper, is that epidemiological research proceed in a sort of haphazard way, where when one day you read on a newspaper that chocolate is good for your health, the day after you read that chocolate is bad for your health, and the day after you read that chocolate is good only if you are aged more than 50 and stuff like this. So the impression that sometimes lay people have of epidemiology is something similar to this vignette, in which we see that there is a presenter, here a showman that say, well, according to a report released today, then this guy will press a button and the 3 fortune wheels will go around, and then they will stop in just random positions that create the news of the day. Obviously, epidemiology is not like this, and I will try to demystify this impression in the last 1 hour. But it is important to understand that sometimes there is this misconception, and we need to understand how we can try to contrast this kind of misconception. Most of epidemiological research basically end up with a very simple question. Very simple just in the way it's framed, not in the answer. And the question is, does A cause B? So, for example, does smoking cause lung cancer? Or does eating vegetables reduce the risk of getting some kind of cancer? In a nutshell, most of the epidemiological research, especially for what it concerns analytic epidemiology and also in some way clinical epidemiology, end up with this kind of questions about causation, about causality. So let's try to refresh what a cause is before going on. We have here a very classic definition of causation. That is, A is the cause of B, means that when A happens, B invariably follows. This is a very mechanicistic definition of causation that works very well in some situation. Like, for example, if I'm working on a very simple physical experiments. But what do you think? Do you feel that this definition is relevant in biomedical sciences? Do you feel that smoking could be considered a cause of lung cancer according to this definition? What do you think? Coraggio. Why not? Exactly. It would be much easier to state that smoking is a cause of lung cancer, where if every smoker sooner or later gets lung cancer, and nobody who does not smoke gets lung cancer. Reality is completely different. We have some very lucky individuals who are chain smokers, but they still do not develop any lung cancer. And on the other side, there are some very unlucky people who are not smokers, who are not exposed to any known carcinogen, but unfortunately they develop lung cancer. So this means that this classical definition of cause is actually not useful in biomedical research. It does not help us, because if we want to evaluate whether smoking is a cause or not of lung cancer, what we are implying is something different from what is written here. What can be this kind of implication? How would you frame the concept of cause in a biomedical framework? Okay, and what do you mean with the risk factor? Exactly. What we usually, when we talk about causes in epidemiology, we basically talk about probabilities. So, for example, it's we see here a definition of a cause that is more sensitive in an epidemiological framework, as a factor that is associated with the disease, so that if the intensity of the prevalence of the factor in the population is changed, the incidence of disease also changed. This means that the concept of cause is act at the population level. So we can still use in some way the previous definition, but only if we talk about a group level. So we can say that a population where everybody is smoking will have higher rates of lung cancer than a population where nobody smokes. Okay, this is a sort of natural law. Okay, is true 100%, but we cannot infer any conclusions of this kind at the individual level. At the individual level, the concept of cause, as your colleague suggested, becomes a statement about probability. So at the individual level, the concept of cause becomes something like, if you smoke, you have a higher probability of getting lung cancer than if you don't smoke. Okay? So we have now to deal with something different from the typical idea of causation, and we have to deal with something different, that is the concept of association. And we need to understand whether an association is causal. So if this association implies really a sort of cause and effect phenomenon underlying what we are observing. So what is association, and how this concept is different from causation? Association is a statistical concept, so it can be defined in a statistical way. And one of the definitions is that we have an association between two variables. When the level of one variable differs, the level of the other variables differs as well. So there is a change of the two variables tend to change in some way when they are in some way connected. So a change of one of the variables, the levels of one of the variables, allows you to predict in some way the levels of the second variables. But this does not necessarily mean that there is a causal association between these two variables. Some of the associations can be causal. In this case, this means really that A is a risk factor for B. Okay, so smoking is a risk factor for lung cancer, for example. but many other associations that we can observe in an epidemiological study are in fact not causal, are due to other reasons. For example, are due to chance, or are due to other aspects that we will see in detail after, called bias or confounding. So, again, making a very strong oversimplification, most of the work of an epidemiologist is try to understand whether, first of all, to measure is to measure associations, so to see if there is an association between two variables, from an exposure and a disease. But the second step is to try to understand whether this association is causal or not causal. And we will try to understand during this talk a few tricks or few concepts that we need to know to help us to conclude whether an association is causal or not. First of all, how can we measure associations? Well, we have some epidemiological measures that are called relative measures of association that works just very finely to measure the strength of an association between a putative risk factor or a putative protective factor and a health outcome. The most famous one is the relative risk. Probably you have heard about this. Have you ever heard about relative risk? Who has never heard about relative risk? Never? So everybody knows what relative risk is? Anybody wants to tell me what relative risk is? Also, even in Italian, if you prefer. Quale potrebbe essere una definizione di cos'è il rischio relativo in soldoni? Well, imagine that we have a group of smokers and a group of non-smokers. You want to evaluate whether smoking increases the risk of getting lung cancer. What is the most logical study to conduct? Okay, this is the definition of relative risk. So what we do is that we measure risk in smokers, we measure risk of getting lung cancer in non-smokers, and then we compare these two risks. And we make just a ratio of these two risks. So if I find a relative risk of 2, this means that the risk of smokers is 2 times higher than the risk of non-smokers of getting lung cancer. Okay? If I find a relative risk of 0.5, this means that the risk of the exposed people, let's say the smokers, is a half of the risk of non-smokers of getting lung cancer. Obviously, this second statement is false, okay? Because we know that the risk is higher in smokers than in non-smokers. But for example, if I run an epidemiological study to evaluate the effect of vegetables, eating vegetables, and risk of getting colon cancer, I will find a relative risk of 0.7. This means that the risk of people eating a lot of vegetables is basically 30% lower than the risk of people who do not eat much vegetables of getting colon cancer. Okay? Is the interpretation of relative risk clear? Okay, fantastic. You can forget, for the sake of this presentation, the other two measures. In some way, they try just to approximate the relative risk. Okay? So, step 1, we conduct an epidemiological study and we measure the strength of an association. We find, for example, that our putative risk factor is associated with the disease, whatever disease you like, with a relative risk of 3, for example. Okay? This is step 1. But this is just step 1. This is not the end of our journey. Because after that we find an association, we need to evaluate whether this association is causal or not. So the first check that we need to do is to evaluate whether these results can come from chance. Then we can see whether there is some kind of problems in the conduction of the epidemiological study for which we have a result that is instead wrong, that is spurious. And then we can go on and try to use some other criteria that we will see later. Only at the end of this process, we can state confidently that a specific exposure is a risk factor or a protective factor for a specific disease. And then at this point, we can recommend some kind of intervention. Before of that, we cannot recommend any kind of intervention. We cannot suggest the specific medication. We cannot ban the specific exposure from the population because we don't have enough evidence that this factor is associated with the disease. Chance. This is the most important responsible of results in research. Most of the results that we find in whatever kind of research is often due just to chance, especially if these results are completely unexpected. Let's have an example. This is a clinical trial. We try to see whether our experimental drug is more effective than taking a placebo. So, do you all know what a placebo is? What is a placebo? Anybody wants to give a definition of placebo? Coraggio. I know that is now we are all. You can speak. You can comment in Italian if you like. I know that this is a very difficult time. Exactly. So we have basically a fake drug. Let's imagine that we want to compare a new drug. We make also a fake drug, and we give half of the subjects the real drug, and half of the subjects we give the fake drug, and we want to see whether the real drug works better than doing a fake drug. If they works in the same way, this means that the real drug is completely ineffective. It doesn't work at all, okay? So these are the results of our study. We are looking at 1-year mortality for these subjects. We see that in the experimental drug arm, we have 8% of chance of dying. So 8% of subjects died during this year, while in the placebo group, the frequency of deaths was 15%. So what do you think from these results? Are these results suggesting that the drug is working or not? Yeah. Who does not agree on the fact that there is some suggestion that the drug could work? If you're in doubt, just ask yourself, would you prefer to be in the group with 8% of probability of dying or in the group of 15% of probability of dying? I would prefer to stay in the 8%. I mean, obviously, you want to stay in the 0%, but if you need to stay in one of the two groups, it's better to be in the group with 8% of probability of dying than in the group with 15%, okay? This seems like a common sense conclusions. But are these results sufficient? Imagine to work for the Ministry of Health. And imagine that this is the only study which was carried out to evaluate the efficacy of this drug. So these are the only results that we have in hand to decide whether or not to give this new drug to the population, to the patients. Would you think that this is sufficient? Would you recommend this new drug just based on the results of this study or not? Why not? Yeah, probably it's always a good idea to have more studies, but imagine that you need to have to take a decision immediately because this is very serious and we have only this study. Do you think that the results of this study are sufficient to confidently recommend this drug or not? What can be another explanation? I mean, is this difference between these two groups necessarily due to the fact that the drug is effective, or is there another explanation to these results? Chance. Do you all agree that this could be just due to chance? Maybe there are 20 deaths less in the first group compared to the second, no? 25 people versus 45. It is possible that this group of people who died, these 20 people, died because of a car accident. So it's the difference could be completely due to chance. Okay? So we needed to do something to evaluate whether these results are due to chance or not. Okay? Just to give you a sense of why these results can be due to chance. This is a thought experiment that you can do at your home when we will be back tonight. You can take 20 coins. You divide the 20 coins in two groups. You pretend that the first group is called Group A. The second group is called Group B. And you simulate a clinical trial in this way. You toss the coins, and whether the head come up, this means that the patient, the coin, is dead. Okay? We do the experiment. Oof. We have, this is the results of our study. We have 3 deaths in the left group and 5 deaths in the right group. So if you calculate the relative risk, you would obtain 0.6. Now, you know that these are coins. Do you mean that the results of this trial suggest you that these 2 groups of coins are different, that they have really different probabilities of having a result instead of one side instead of the other of the coin? Or do you instead think that it's just chance? It's just chance. In fact, if we toss the coins again, maybe we can find just the opposite results, okay? So we have just the results that we have, they are just going around the expectation, but they are not so different from the expectation to suggest us that there is something different in these 2 groups. Now imagine that instead I toss the coins and and in one of the 2 groups we have all heads, so all dead. So now, well, 10 heads out of 10 is start to be something, an event that is quite unlikely. So I can start thinking that maybe there was some kind of trick. Maybe the person tossing the coin was a person skilled to do this kind of tricks, or maybe the coins are in some way fake, and the probability of getting head is not exactly 50%. But we need what? We need a very extreme result. Otherwise, we don't know if the results are due to chance or not. We have the same problem in clinical trials or in whatever kind of epidemiological studies. If the results in the 2 groups are not that different, we don't really know whether results are due to chance or not. In one of the next classes, I think that you will be introduced to the concept of how to calculate the probability that the results of your study is due to chance. So using the p-value and the confidence intervals. I will not cover this part today, but what you need to know is that basically statistics gives us the tools to evaluate whether our results are plausibly due to chance or not. Okay? So we have some kind of tools to try to overcome the first step, evaluate the role of chance. But now we have some other kind of problems that instead cannot be accommodated easily with a statistical tool. And so we need to think and we need to reason on whether there is a problem in our study or not, and whether this problem can have produced the results. Imagine that this is a target, and I'm just shooting with a gun to the target. Two things can happen, basically. Well, that can happen. There can be different situations, but let's focus on these two situations. In the first case, we have a situation in which the person, the gunner, is actually quite precise, and all the missiles the bullets that you shoot go more or less in the same area, but this area is far from the center of the target. In this case, we say that the results that the shooter is precise, so he can repeat more or less the same kind of the same part of the target, but it's not very accurate, because even if he will shoot for 100 times, will probably never hit the center of the target. In the second situation, instead, we have a shooter that is accurate but not very precise. His hands is a little bit going back and forth, and so sometimes randomly the bullets go sometimes on the left, sometimes on the right, sometimes up, sometimes down the very center. But if you wait enough, in this case, in this second case, sooner or later one bullet will hit the center of the target. Now, the problems related with chance are more similar to this second scenario, in which we have basically an impression, our estimate is not very precise. The thing we will now talk instead is a problem of accuracy, when our study has some kind of flow, some kind of problem, for which instead of shooting there, I shoot there. So I'm not looking at the right target. So even if I'm very precise, I will never hit the right target. Imagine, if you like, the metaphor of a scale, una bilancia. A scale can be precise, accurate, or not accurate, not precise. If the scale is not precise, this means that if I go over the scale 2 times, probably I will not find the same weight. If the scale is not, this is when the scale is not precise. If the scale is not accurate, this means that the scale basically measure a wrong weight. I can go over this scale for 100 times, and every time the scale maybe will give a weight that is 5 kilos more or 5 kilos less. In the same way, an epidemiological study can have the same defect of a scale and measuring a wrong result in a systematic way, okay? And now we'll try to see what are the most important mechanisms that can cause this kind of distortion of the results. The first class of mechanism that can cause this kind of distortion of the results is called bias. And in particular, we recognize two important kinds of bias in epidemiological studies. That is called selection bias and information bias. Selection bias is when the people that were recruited in one group have been recruited in a way that is different of the people that ends up in the second group. So these two groups are no more comparable, okay? And I will give you an example very, very, very soon. The information bias instead is when the quality of the information is different in the two groups. Is there any comments, question? Okay, no, sorry, I just saw. Imagine, let's see selection bias in action. Imagine that I carry out an epidemiological study in which a study that is a typical epidemiological study is called case control study. How does the case control study work? Very simple, in principle. I take, for example, 100 patients with the disease. I randomly draw from the population, let's say, 100 people without the disease, and I compare whether the exposure is different between these two groups. Okay? Very simple. For example, I go to the hospital and I take all the people with the lung cancer. Then I draw randomly from the population of Varese 100 people without lung cancer. Then I interview them and I ask them, do you smoke? If smoking is a cause of lung cancer, I expect then the proportion of smokers will be much higher in lung cancer cases than in the healthy controls. Okay? Now, let's try to remember what happened the last time that somebody called you at the telephone to ask you to participate in a survey, maybe in a commercial or a political survey, un sondaggio. What did you do? Oh, hello, I'm here for a survey, click. After 2 seconds, you just decided not to participate to the survey. Why? Because you are busy. Because you have other things to do much more important, okay? This is how the people behave. And this also happened in epidemiological studies. So what typically happens in these kind of studies is that some people decide not to participate to the study. These people are called non-respondents. They sometimes do not participate at all. Sometimes they decide not to answer some specific question, maybe because it's a sensitive question, like do you use drugs, stuff like this. So we have some people that are not participating to the study, basically. Now, so this means that we have a selection of the subjects in one of the two groups or in both of the two groups. If the selection is different, the selection mechanism works differently in the two groups, you will introduce a distortion of the results. You will find a result that is wrong. And we have here a simple numerical example. On the left, in black, you have the real study. Let's imagine that everybody participates to the study, okay? So the result that we found down is the odds ratio that you can interpret like a relative risk, is the real result, okay? The correct one. And we have a relative risk of 3, okay? Now, imagine that we have a small proportion of subjects who do not participate to the study. You see that there are not many people, like 10% in one group, 20 in the other. But even this small proportion of people who decide not to participate can, in some situations, can introduce bias. And in fact, you see that when the people decide not to participate, we have the result here, and the result becomes different from the original one. The result that we now find is 2.67 and not 3. In this case, this difference can be much larger than in this fictional example, okay? And this happened only because the proportion of people who decide not to participate was different in the different different 4 cells of this study. So you can check if you like when you are at home that I just subtract a different proportion from these cells according to this percentage, and I end up with a result that is different. So the association that I found is now wrong, because the real association is 3, not 2.67, okay? Information bias. In information bias, the problem is not that there is a selection of the participants. All the participants participate to the study, but the quality of the information is different between the 2 groups. Let's imagine that we have a situation like the previous one, in which we have a case control study, and these are the real results. So the true relative risk should be 5, okay? Now imagine, as it happens every time, that we are doing an interview, maybe some information is not recorded in the right way, because maybe the patient does not tell the truth, or does not remember well, or the person doing the interview make just a mistake and classify the person as exposed, as a smoker, while instead this person is a non-smoker. This happens. This happens in every kind of interview that we do. That there will be some proportion of mistakes. We hope that will be very little, but there will be some mistakes. So now imagine that this is a very, very plausible situation, that by mistake, 20% of the cases unexposed, let's imagine there are no smokers, are erroneously classified as exposed, and the other way around for the exposed subjects, okay? So we will see that there will be some subject that will go from this cell to this cell, and some subject that will go from this cell to this cell, okay? I'm just moving the 20% of people from the upper left cell, the 50 people, to the upper right cell, and I'm moving the 20% of subjects from the right upper cell to the left upper cell. The results now changed. So now we have a spurious result. The true result was 5, now we have 6.37. It seems maybe that this is not a big difference, but in some situations this can make a lot of difference, okay? So what is the problem of bias? The problem of bias is that this distortion of the results that is due to a defect of the design of the study, or the carrying out, the conduction of the study, can change the results. And can change the results in any direction, can sometimes exaggerate the association. In some other situations, can instead obscure the association. So we can see an association that is in fact not real, or we can fail to identify an association that is instead real. The big problem compared to chance, to the problems of chance, is the fact that that increasing the study size will not remove it. Usually, when you have a problem of chance results, if you double the sample size of your study, you will end up having more precise results. So you can deal with problem of precision recruiting more patients. While if you have a problem in the quality of the study, you don't resolve the problem in recruiting more patients. What you need to do is to know that this problem can happen, and to be very careful to the study design first, and then to the conduction of the study. Third situation, let's have a look to this picture. What happened here? There is an epidemiological study that has just been published, and you see that on the back. And it shows a very strong association between ice cream sales and murder rates. So there is a very strong association between days when a lot of ice creams are sold and the murder rate, the number of people who are murdered. Do you think that this association is real, is true? What is the real explanation for this association? We have an hint in front of this vignette. What does the person saying? Excuse me? The temperature, yeah, exactly. There is a person who is probably just a madman that just comes out from a bush and say, oh, today is very hot. I would kill for an ice cream. So what is the real explanation for the association? Is real. There is really an association between ice cream sales and murder rates, but this association is not causal. So if I reduce the sales of ice creams, I will not obtain less murders in my country. Why? Because, in fact, there is a third factor, which is the real cause of both variables, both the exposure and the disease or the health effect. And what is the real culprit? The real culprit is heat. When, in the days when there is more, in the hottest days, people tend to consume more ice creams. And for some reason that we still don't know completely, when during hot days, people tend to go crazy more easily. And so the number of murders increase during very hot days, okay? So if we measure an association between these two variables, we will find every time that we will measure an association, in any country, we will find an association between these two variables, but this association is there, but is not real, is not causal, okay? The real culprit is the heat. How would we call this kind of phenomenon? We call it confounding. A confounder is a third factor that is not, we have the exposure, in which we are interested in, and we have the outcome. We are interested in the association between these two variables, but there is a third factor that we were not very interested in. Sometimes we didn't even know that was around. This third factor has some specific characteristics. It's associated with the exposure we are studying, is associated with the disease we are studying, the disease or the health status like murders, and is not a consequence of the exposure, is not what is called a mediator. Let's see a real example of confounding in epidemiology. Let's imagine that I want to evaluate whether smoking is associated with myocardial infarction. So the association I'm interested in is the one with the dash lines, okay? That connect, the dash arrow, that connect exposure with disease. But some of you can tell me, well, there is a problem here, because men tend to have a higher risk of myocardial infarction than women. And men, at least in some countries, tend to smoke more than women. So if you just compare, if you just measure the association between smoking and myocardial infarction, in fact, we are not measuring only the association, the possible association between smoking and myocardial infarction, but we are also measuring a part, the fact that the smokers will tend to have a higher risk of myocardial infarction because they have a higher probability of being men instead of women, okay? You can see in a graphical way that there is another reason that links the exposure with the disease here. So we need to accommodate the effect of this third variable called the confounder. In the second line instead, this is not a real confounder. This is called just a mediator. Somebody could tell, well, maybe you should take into account the effect of hypertension when you measure the association between smoking and myocardial infarction. In fact, this would be wrong because hypertension could be just one of the many biological mechanisms through which smoking could cause myocardial infarction, okay? In this case, hypertension is not a confounder. You see that all the arrows are dashed in this case because there are just different mechanisms that are involved in the causal association between smoking and myocardial infarction. While in the first case, I need in some way to take into account the effect, the possible effect of this third factor called the confounder. This is a very well-known example of confounding that puzzled the researchers in the 70s. During the 70s, different studies found that there was an association between the birth order of the children and the risk of getting Down syndrome. Let's look at the left graph first. So you see that there is a very clear association between, if you are the first child, you have a very small probability of having Down syndrome. If you are the third child, you have a much higher probability of getting Down syndrome, okay? So researchers started to speculate on what could be the biological mechanism that could explain this very strange association. Until a researcher pointed out a very important fact, the fact that we already knew a very strong risk factor for Down syndrome, that is maternal age. If a mother is more than 37, this mother has a much higher probability of getting or of having a child with Down syndrome than a very young mother, okay? So now, if you think a moment, if you take a child who is the first child in a family and a child who is the third child in the family, who is the child with the higher probability of having an old mother? The third one, because obviously the mother needs first to have the other two. So here you can have you can see confounding in action. This was the results on the left were what we call the crude results, which were in fact wrong. We said that they are confounded by the effect of this third variable. If we stratify the results by the maternal age, so if you say, okay, let's compare first child with the third child, but taking people who have mothers of the same age at the moment of the birth, you see, and so if you work on, in this order, if you work in this order, so in this way, you will see now that the probability of having Down syndrome is the same for subjects coming, whatever is their birth order, okay? This is a clear situation in which the association that we saw was in fact spurious and was completely due only to confounding, okay? Once that we took into account confounding, the association disappeared completely because it was only due to the fact that third children were tended to have older mothers than first children. So how can we deal with confounding? Well, there are basically two main options. First, in study design. So when we design the study, we have some kind of options that we can try to use. I will not go in depth on this, but it's important to know that it's very good to try to adjust the result, to take into account the possible effect of confounding during the study design, so before carrying out the study. And I just note the fact that one of the most powerful way to take into account confounding is in fact a randomization. When I can randomize, randomization is very powerful to take into account the effect of confounding. So if I have a randomization, usually I can not be worried. I have the possibility not to be worried about confounding. But not always it's possible to randomize. So sometimes I need to use other kind of options. Or in the analysis stage, I can use some kind of statistical machineries to try to adjust for the effects of confounders. But in this case, it's very important that I can adjust only for confounders that I have measured. So I needed to think about confounding before carrying out the study. Because if at the analysis stage, I realize that I needed to adjust for maternal age, and I haven't recorded this information in my study, I'm done. There's nothing that I can do. While if I have recorded this information, in this case, I have some kind of statistical options to adjust the results for the effect of these possible confounders. So if so let's imagine that I'm happy with with stage 1. I think the results of my study are not due to chance and reasonably are not due to bias or confounders or confounding. In this case, I can try to go on and try to consider other criteria for causality that can help me to conclude at the end whether the association that I'm studying is a causal association or not. This person is called Bradford-Hill and is one of the fathers of medical statistics and epidemiology. When in the 60s, when he had to deal with the problem of deciding whether or not smoking was a cause of lung cancer, this was the big question in the 60s, he ended up with these criteria. These criteria were not taught like a sort of cookery book to follow, and at the end you have an algorithm in which you have 100% sure whether or not the association is causal or not. But you should see these criteria more like a sort of a checklist to help researchers to evaluate the plausibility of causation. Some of these criteria are epidemiological, statistical in nature, while others instead are more logical or biological in nature, indicating the fact that very often we need to use some extra statistical reasoning to decide whether an epidemiological association is causal or not. What are these kind of criteria? Well, the first one say, what is the strength of the association? We learned that we can measure the strength of association through relative risk. What Bradford-Hill says was, well, it's more plausible that the association is causal if we have found a very strong result. So, for example, a very high relative risk, like let's say over 5. While if you find a very small increase of relative risk, let's imagine 1.3 in the relative risk. In this case, it's possible that a small defect in the conduction of the study can have caused this result. While if you have found a very strong result, if you find a relative risk of 10, it's very unlikely that this can be due to a defect in the conduction of the study. In this case, the defect should be huge, something that is very easy to identify. The second criterion is just what we talk about bias and confounding. Basically, you need to check whether your results are robust to adjustment for some known confounders of the association. The third criterion is not used anymore. It's something that came from the era of infectious disease, in which there was one agent for one disease. So you have HIV virus for AIDS, and so on. We now know that for a non-communicable disease, this relation is not true anymore. For example, smoking is a cause of different disease. So we don't need necessarily to find a one-to-one relation. So the third criterion is not used anymore, and is just told for a historical reason. The fourth one is instead very, very important, and it relates with what your colleague said earlier. You never, for practical purposes, you never draw a conclusion of causation basing on one single study. You need many studies, possibly studies conducted with different approaches on different subjects in different countries. And if the results are consistent among the studies, this is a very strong hint that this association is causal. While if you don't find consistency, this speaks against a causal association. Let's imagine, for example, that you carry out studies on smoking and lung cancer in America and in Europe. You expect the results should be more or less the same. If you find that the effect was very strong in Europe, but was null in America, this would speak much against a causal association between smoking and lung cancer, because you say, well, smoking more or less is the same as the kind of chemicals involved in America and in Europe. The human beings are the same in US and Europe, so I would expect to see the same results. So if you don't find the consistency, you should stop and think very carefully whether this association is strong or not. Temporal sequence is fundamental. So it's a cause must always precede the consequence. So you need to be able to show that exposure preceded the outcome in your study. This seems obvious for logical purposes, but is not necessarily easy to do in an epidemiological study. Imagine, for example, that you carry out what is called a cross-sectional study, in which in the same moment of time, you measure both the exposure and the outcome. For example, I draw a random sample of the population of Varese, and I interview them, and I ask them, do you smoke? Yes, not. Do you have asthma? Yes, not. In this case, I don't really know, in fact, whether these people started or changed their status of smokers before or after a diagnosis of asthma. So, for example, could happen paradoxically, that I can find that the group of asthma patients has a lower proportion of smokers than the healthy subjects. Why? Not because smoking is a protective factor for asthma, but just because after that you were diagnosed with asthma, the doctor tells you to quit smoking. So if you just take a moment in time, you are not able to understand whether the exposure really preceded the outcome. Dose-response relationship is a concept that comes from toxicology and is very important in epidemiology as well. It's important to show that smokers have a higher risk of getting infection or lung cancer, but it's even more important to show that among smokers, the risk of getting the disease increase with the number of smoked cigarettes. Okay, this makes a lot of sense on a biological point of view. Plausibility. Plausibility, obviously, if you know a possible mechanism involved, this speaks much in favor of an association, of a causal association. While if you don't know the mechanism, or even worse, if the mechanism seems implausible, obviously this will speak against a conclusion of causation. And then the last criterion is reversibility. If you are able to show through an intervention study that blocking the exposure improve the health of the subjects, obviously this speaks much more in favor of a causal association. So if I am able to show that smokers that quit smoking start to have a risk, basically have a risk of lung cancer that is intermediate between smokers, current smokers, and non-smokers, this speaks much in favor of a causal association, because I'm showing that basically eliminating the exposure reduces the risk again. So it's difficult to make drawing a conclusion of causation in epidemiology is very difficult, especially because we usually deal with not with diseases that have only one cause, but we deal usually with non-communicable diseases that have multiple putative causes. And it is very important to be aware of the fact that there is a very clear difference between association and causation. There is a sort of saying in epidemiological research that the association does not necessarily implies causation. We need to have an association before starting talking about possible causation, but this is just the step one. Then we need to evaluate whether or not this association is a causal association or not. Okay, we have now, I think I still have 10 minutes, is it correct? Okay, I have a case study, but probably will not be able to go through it. So maybe, I don't know if we want to talk, and instead if you have any comment or any question on this. Do you have any question, any comment? Okay, please. Well, usually in medicine we have these two big classes of diseases: the communicable disease that can be transmitted by a subject to another. So we are talking basically about infectious disease. And all the others, they are called non-communicable disease. So we are referring to cancer, metabolic disease like diabetes, myocardial infarction, cardiovascular disease in general. So most of the disease that constitute a burden, the most important burden of disease for industrialized countries like Italy, are in fact a non-communicable disease. We are now much more concerned, and we run many more studies for non-communicable disease than for communicable disease. Okay, for what it concerns this presentation, the important point is that while for communicable disease you have usually one cause of the disease, that is the microorganism involved, then you can have also some risk factors, because then can modulate the probability of getting sick. So for example, obviously the risk factor for AIDS is the HIV virus, but then if a subject is using drugs and they exchange syringe, or if the subject is involved in prostitution, obviously the probability of getting infected changed. But still the cause of the disease is still the microorganism. Okay, and we have only one microorganism that cause this disease. For cardiovascular disease, for myocardial infarction, for lung cancer, you don't have such a unique agent. You cannot say that, that smoking is the only cause of lung cancer, because you also have asbestos, you have air pollution, you have diet at some extent, we have a lack of physical exercise, and so on. So this is very important, because the relation, in this case, the relation between in fact, we introduced the term risk factor instead of a cause in non-communicable disease epidemiology, because we are aware of the fact that the relation between this exposure and the disease is a kind of probabilistic relation, in which we are 100% sure of the fact that, that smoking increases the risk of lung cancer. But the kind of relation that exists between smoking and lung cancer is completely different from the relation, the mechanical relation that exists between the HIV virus and the AIDS syndrome, okay? I don't know if it is clear. Any other question or comment? Okay, so maybe we can have a short break and then we can go to the next lecture. Thank you very much. Sorry, I would leave the case study as a sort of exercise or as a sort of homework for you. So you can try to use, there is a real case study, and that try to, in some way, to use some of the concepts that I introduced. And so you can try to go to this real example and try to see if how to use some of these concepts or some of these tools. Thank you.